This short video is about prematurity. In this video, I will be discussing how to define prematurity and classify neonates by gestational age, identify causes and complications of prematurity, describe treatment and preventive approaches for prematurity related conditions. By definition, neonates who are born before completing 37 weeks of gestation are termed as premature. Premature babies are further classified based on their gestational age. Extremely preterm is the term used for the neonates who are born less than 28 weeks of gestation. Very preterm is used for the neonates who are born between 28 to 31 weeks of gestation. And moderate or late preterm is the term which is used for the neonates who are born between 32 to 36 weeks of gestation. Beyond the 37 weeks of gestation, the neonate is termed as full term. Among the various causes of prematurity, it is found that the incidence of prematurity is higher in the lower socioeconomic group. Similarly, the incidence of premature birth and hence the low birth weight is quite high in primary gravida under the age of 20. Various maternal diseases like pregnancy-induced hypertension, antepartum hemorrhage, chronic infection, malnutrition, and chronic diseases are associated with premature births. Similarly, maternal drug abuse like alcohol or cigarette smoking is also found to be strongly associated with the premature deliveries. Among other causes of prematurity, multiple pregnancies and the fetal anomalies in the form of chromosomal abnormalities or structural anomalies, they are also associated with premature births. Prematurity is associated with certain short-term or long-term complications. Short-term complications usually manifest in the first week of life. However, the long-term complications manifest later in life. Short-term complications include hypothermia, hypoglycemia, feeding difficulties, respiratory distress syndrome, sepsis, necrotizing enterocolitis, intraventricular hemorrhage, jaundice, and PDA. I'll be discussing all these complications one by one. Premature babies are prone to hypothermia due to large surface area, lack of subcutaneous fat. They have poor stores of brown fat and they have less muscular activity. Premature babies are also very prone to hypoglycemia due to inadequate or delayed feeding. They have feeding problems, they have low glycogen stores, and if they develop sepsis, it also leads to hypoglycemia in these newborns. Treatment is usually given by IV 10% dextrose. 2 ml per kg is given stat and it is followed by continuous infusion of 6 to 8 ml per kg per minute if hypoglycemia does not resolve. Feeding difficulties in premature babies is due to poor sucking reflex and poor swallowing reflex. Premature babies develop respiratory distress syndrome due to surfactant deficiency. Surfactant is basically produced by type 2 pneumocytes. Its production starts by 25 to 26 weeks of gestation. Hence, lower the gestation age, lesser the surfactant is produced and more chances of development of RDS in these preterm babies. Surfactant basically helps in expansion of alveoli on inspiration and reduces the degree and speed of collapse during expiration by reducing the surface tension. RDS is better prevented by preventing the premature delivery, by administration of antenatal steroids at recognition of risk of preterm delivery, avoiding caesarean section, and by preventing and treatment of hypoxia, acidosis, and hypothermia. The level of intervention needed depends on the severity of respiratory distress, and it includes respiratory support and administration of surfactant. Necrotizing enterocolitis develop in these preterm babies either due to birth asphyxia, feeding these preterm infants with hypotonic solutions, umbilical catheterization, sepsis, RDS, or polycythemia. Treatment is done by stopping the per-oral feeding, decompression of the stomach, giving total parenteral nutrition, broad-spectrum antibiotics, and surgery in cases of intestinal perforation. Preterm babies acquire infections more readily due to defective immune system. They have low immunoglobulin levels, they have decreased cell-mediated immunity, and they have poor barriers in the form of skin and gastrointestinal tract. Similarly, intracerebral hemorrhages, particularly intraventricular hemorrhages in these babies, are more common, especially if they are born less than 34 weeks of gestation. Cerebral hemorrhage occurs due to hypoxia and deficiency of clotting factor in these preterm babies. They develop jaundice due to immature hepatic enzyme system or poor feeding. After birth, with the aeration of the lungs, the pulmonary vascular resistance falls with increase in pulmonary circulation and increase in oxygen tension. In full-term newborn, PDA closes generally within 48 hours secondary to oxygen-induced constriction. However, in premature infants, PDA does not respond well to increased oxygen tension and it is more likely to persist. Long-term complications include apnea of prematurity, anemia of prematurity, retinopathy of prematurity, bronchopulmonary dysplasia, developmental disabilities, or certain chronic health conditions like asthma, diabetes, or hypertension. Apnea of prematurity is defined as cessation of breathing for 20 seconds or cessation of breathing for any duration that is associated with bradycardia and or change in skin color in the form of pallor or cyanosis. It is very important to differentiate apnea of prematurity with periodic breathing of the newborn. In periodic breathing, there is no associated bradycardia or any change in skin color. For the treatment of apnea of prematurity, first of all, simple tactile stimulation is used. But if these simple measures fail, then the pharmacological treatment in the form of theophylline or caffeine may be required. Even the assisted ventilation may be required. Anemia of prematurity is one of the long-term complications in premature babies and it develops around 8 to 12 weeks of life. Treatment is given usually in the form of iron supplementation, erythropoietin, but if the HB falls less than 10 gram per deciliter, then packed red cell transfusion of 5 to 10 ml per kg body weight should be given. Retinopathy of prematurity is another long-term complication. This condition is particularly common in very low birth weight infants who have been ill in the perinatal period requiring respiratory support. And it develops due to high oxygen administration of more than 40% for prolonged period. And arterial PO2 and oxygen saturations are not monitored and controlled accordingly. In retinopathy of prematurity, there is basically initial vascularization, followed later dilatation of retinal vessels, proliferation of new capillaries and fibrous tissue formation lead to retinal detachment and retrolental fibrosis with blindness. This condition must be prevented by adequate monitoring of inspired oxygen and PO2. All premature babies must have regular ophthalmological examination for 6 months after discharge from hospital. Initial retinal signs of ROP may not be detected within the first few weeks after birth and hence follow-up and eye examination at 4 to 6 weeks of postnatal age is also required. Follow-up every 2 weeks is required until the retina is fully vascularized. Bronchopulmonary dysplasia is chronic lung disease of prematurity. Premature babies' lungs may not be fully developed and they may need extra oxygen and mechanical ventilation early in neonatal life. However, these treatment strategies, while necessary, they can sometimes damage the lungs, causing inflammation and scarring, leading to bronchopulmonary dysplasia. Prematurity significantly increases the risk of neurodevelopmental disorders like cerebral palsy, cognitive delays, and autism spectrum disorders later in life. Similarly, incidence of certain chronic health conditions like asthma, diabetes, hypertension, and heart diseases is also found to be higher in preterm babies. Thank you. This was all about prematurity. If you find it useful, then do share, like, and subscribe.